Hello and welcome to my channel. Today we are going to start our discussion for the initial assessment of a trauma patient. As we all know, the trauma patient is managed according to the ATLS protocol, which has A, B, C, D, and E. Starting with the airway, the adjunct is the cervical spine. With breathing, we have ventilation. With circulation, we have hemorrhage. Then we have disability and exposure control. First of all, for the airway and cervical spine immobilization, what we have to do, we have to immobilize the cervical spine using either cervical or rigid collar. Then followed by immobilization of the cervical spine, we will come and assess the airway. First of all, if you ask the patient their name and they're able to tell you that, it shows that the airway is patent. But if the GCS is overall less than 8, or the patient has signs and symptoms associated with burn, or there is surgical emphysema in the neck region, then you have to keep in mind that the airway can get collapsed. For those patients, we have certain maneuvers and we have to use them in the specific sequence, which includes jaw thrust, chin lift, and these are used to remove any foreign body, blood, or vomit from the mouth. Followed by this, we have to move towards the Guidal's airway, and after that, there are certain steps for which include endotracheal intubation. And if endotracheal intubation fails, or in case of burn, there is already upper airway edema established, then we will move towards the cricothyroidotomy. Talking about the indications for intubation, if the GCS is less than 8, or the airway is compromised, the patient is unable to oxygenate, or there is rapid deterioration in the overall condition of the patient, then we have to intubate the patient. A key note is that the burn patients are likely to develop airway obstruction post edema, so it is likely to go with the airway protection beforehand. Then we have breathing and ventilation. In this, we will look for the chest rise and fall, auscultate for the hemopneumothorax, and there could be bradypnea due to intoxication. In that case, we have to intubate the patient. If there is tachypnea, which can result into increased intra-abdominal pressure or respiratory failure, then again, we have to intubate the patient. In case of hemo or pneumothorax or flared chest intubation is the treatment option. So now talking about the circulation and hemorrhage. In terms of circulation, our first aim is to see whether the patient is bleeding through any wound. Is there any external hemorrhage present? We have to stop it. Followed by that, in circulation, it is very important to check for the sign of shock and to classify the patient into type of shock. So the initial step is to have the vital charts. Get the heart rate and blood pressure. Assess the extremities for distal pulse and perfusion. The very important is the capillary refill. Then check the skin color and turgidity. Followed by establishment of the shock in trauma patient, what we have to do, we have to obtain 2 large IV line in the cubital fossa, if available, 16G or 18G. Followed by intraosseous line that is established in the proximal tibia, especially for the children whose veins are not available. Followed by this, the third option is the central venous line establishment. After establishing the venous line, we will rush the fluids, and the choice is crystalloids. However, blood has an equal importance. Followed by this, as I've explained in this part, that is equal importance of controlling the external hemorrhage, which can be done by putting your hand, establishing some pressure, or applying tourniquet. But tourniquet should not be applied for more than 60 minutes. Followed by that, if there is major vessel bleed, we can go with the ligation or with the laparotomy. Now, in all of these scenarios, after establishing the baseline vitals and giving some resuscitation, the most important thing is the FAST scan, which is the focused assessment with sonography for trauma patients. Now, what is done is we see for the chest cavity, abdominal cavity, pelvic cavity, and now with the EFAST, even the cardiac cavity to evaluate for any active bleeders. So first scan is very important. So next we have disability and neurological assessment. In this we have to assess not only the GCS of the patient, but we will be assessing the spinal cord for any injury. In terms of the GCS, we have divided it into 3 components: I, verbal response, and the motor response. I is divided into 4 marks, verbal response has 5, and motor response has 6 marks in total. If the patient is opening their eyes on their own, then the patient will have 4 points. If the patient is responding after being asked, then it will have 3 points. But if the patient is having eye opening only at painful stimulus, the patient will get 2 points. If there is no response, then they will be 1 point. If the patient is well oriented, they know their name, they know that they're in the hospital, they will get 5 marks. If they are confused, they are taking some time to assess the questions which you are asking them, they will get 4 points. If they're only speaking inappropriate words, then 3 points. For inappropriate sounds, we will give them 2 points. If there is no response, then 1 point. If the patient is obeying the command, then we will give them 6 points. But if they move to localized pain, then 5. If they withdraw from the pain, then 4. If there is a flexion response to a painful stimulus, that is, if the patient is being pressurized or pinched over the chest or the forehead and they flex at their elbow or at their knees, it will have 3 points. But if the response is in terms of extension, then it will get 2 points, and if there is no response, patient will get 1 point. So the minimum is 3 and the maximum is 15 for GCS. Next up we have the neurological assessment of the patient. In this we have pupil size and reactivity. The important point to note here is that for ipsilateral dilated pupil, it is a sign of raised intracranial pressure, followed by orientation, for which we have assessed the patient on the GCS score. This will help us to identify whether the patient is in hypovolemic shock, neurogenic shock, or spinal shock. Then we will assess the patient's motor and sensory response in all the dermatomes from head to toe. This will help us to identify presence or rule out any spinal cord injury, and we will be getting pinpoint for the damage if we know about the dermatome. For the neurological assessment, the important step is the log roll for spinal assessment. In this, we require about 5 people. 1 will be stabilizing the head and the cervical spine. 3 will be moving the patient in one position so that the next person who is part of the team will assess the back. So next we have the digital rectal examination, which is part of the disability and neurological assessment. If there is a rectal injury, then there will be blood at the DRE. For urethral injury, there will be high riding prostate at DRE. And to identify spinal cord injury, one can find degrees or absent rectal toe. So these points are very important to identify 3 different pathologies, which include rectal pathology, urethral injury, or spinal cord injury. Then next up we have the exposure and environmental control. For this we have to expose the patient, but at the same time keep them warm. Now there are 2 small sub parts of this ATLS protocol, that is the Foley catheterization and finger stick glucose test. For Foley catheterization, one thing is important. If we are suspecting urethral injury, then Foley catheterization is contraindicated. If there is blood at the meatus or there is high riding prostate on the digital rectal examination, or on examination there is a visible scrotal or perineal hematoma, these all will suggest urethral injury. In terms of investigations, which is usually asked in an MCQ, is the retrograde cystourethrogram. Now this investigation is used to evaluate the urethral injury for trauma patients. Then we have to identify the glucose levels, whether the patient is having hypo or hyperglycemia secondary to trauma. So after completing our primary survey and we have assessed that the patient is stable, we will move towards the secondary survey. In secondary survey, the most important component is history, and it has the mnemonic that is ample. We have to ask whether the patient is having any known allergy so that we can rule out for the presence of any anaphylactic shock. Then, whether the patient is taking any specific medication, as anticoagulants like aspirin or warfarin can increase the risk of hemorrhage. So, if there is an old age patient who came with a fall and they require a surgery, then the risk of hemorrhage must be explained to them. So, this can be checked once we take the history. And then we have to ask for any past medical history. And lastly, now this is important, is if the patient requires an immediate surgery, as in case of any firearm injury or a polytrauma patient, then we have to ask about the event. So what was the mechanism of injury? So a short overview about the important imaging in a trauma patient to help us identify or pinpoint specific injury. First of all, we have the cervical spine. Lateral cervical spine X-ray is the most commonly used X-ray to identify or rule out cervical spine injury. If we are not clear, we can move towards the neck. For chest, a simple chest X-ray PA view can help us rule out lethal valve. We will talk about these lethal valve injuries in the subsequent lecture. In pelvis trauma, X-ray pelvis can help us identify any visible pelvic fracture. If we are suspecting pelvic trauma and the patient is hypotensive, the unknown source of hemorrhage, then we will not proceed with the CT scan, but we will proceed with the actual management, which I will explain in the pelvis trauma management section. So this is the flow chart to give you an idea about the ATLS guidelines, which is divided into the primary survey as well as the secondary survey. Primary survey, we have the airway and cervical spine management, followed by breathing with ventilation, circulation and hemorrhage control, disability, and exposure. In terms of secondary survey, we had allergy, medication, past medical history, last meal, and event of surgery. So I hope this video is helpful. So do let me know in the comment that which lethal valve injury you would like me to make next video on. So thank you very much for listening.